You guys see my screen okay?
Yeah, we got that, Kevin.
Okay, very good. All right, so we're going to talk a little bit about the pediatric metacarpophalangeal joint dislocation, and we'll go from there. Thanks again for coming, and I'm glad to be a part of this group again. Thanks for an invitation again, Cheska. Let's see. So I have no disclosures other than a lot of us on this call put together some book chapters for this awesome textbook about pediatric hand injuries. It's available through the ASSH. I get no royalties from this book. I just enjoy it. I think it's a great book. It's really a good handbook, quote unquote, for the pediatric hand trauma, and it's really worth putting on your shelf. Outside of that, we're going to talk about MCP dislocations. Right, they are actually more common than IP dislocations in children. And the thumb MCP joint is the most common joint hand dislocation that you see in kids. It is more common in the border digits, the index and small finger. That's because the middle finger, ring finger are somewhat protected by the other structures nearby. And so you don't get the stress concentrated like you do on the border digits. And we kind of count the thumb as a bilateral border digit, right? Because there's no finger on either side of it. In this case, dorsal dislocations are much more common than volar dislocations, which generally happen from significant high energy trauma to those joints. And in kids, we have to remember that ligaments are strong, right? Ligaments have a really high tensile force and tensile strength, and thus they do not easily tear. And so instead, they'll pull through the physis because they attach to the epiphysis. Usually at the MCP joint, right, there's two epiphyses on each side. It's the only joint in the hand where there's an epiphysis on both sides of the joint. And so you have injuries generally to the physis rather than through the ligaments themselves. So you can think of transphyseal injuries. You can see ligament avulsion fractures. You can see large joint osteochondral avulsion fractures with the ligaments. So these are all things you have to watch out for when you see a dislocation in kids. The other thing is that a lot of the structures aren't ossified yet as well. So you don't see as much of the cartilage as you see of the bone, even with the sesamoids, which become important later when we talk about this a bit more. So most of the time, these are a hyperextension injury. It's happened very commonly in ball sports injuries. So people who are trying to stop a ball, usually a heavier ball like a basketball, it could be handball or other sports that Europeans do that we don't do in America. Cricket for all those in the English Commonwealth with the new king now ruling over them. And the other mechanism is the fouche injury. When you fall, put your hand out and then hyperextend the hand when you kind of roll over your hand. It can also happen for a direct blow to the MCP joint. More often in the volar dislocations, you have to have a really significant direct blow to dislocate the whole joint volarly. And then you end up generally with the hyperextended posture of the joint. It doesn't bend correctly. It's somewhat swollen. And the swelling can be pretty severe and it can hide the dislocation in some cases because of the way the dislocation happens. So it's important to get good x-rays and be very cognizant of these injuries when you see these patients. Typically, we're getting these done in the emergency room and we have the x-rays before we're consulted, but sometimes they consult us for deformity or some weird swelling. I think it might be an infection, but it's actually a dislocation. So as with all patients, I really want to get a good history because you want to know what they did, how it happened. Was it hyperextension injury? Did they jam their finger, quote unquote? Or is it a fall? And then the immediate treatment. I've actually had a patient who she was playing basketball, dislocated her MCP joint, and she's like, "That's cool," and took a picture of it with her phone. And then she popped it back into place and then took another picture. And so when I was seeing her in the office, I was sort of questioning what happened. And she's like, here's the first picture, here's the second picture. So we had a good understanding that she actually had a simple MCP dislocation of her index finger and was able to pop it back into place. The other thing is the neurovascular status, right? Because when these generally happen on a dorsal dislocation, the metacarpal head goes volarly, and that puts a lot of stretch on the neurovascular bundles, especially the radial digital artery and nerve on the index finger, as well as on the small finger. So that can cause some neurovascular compromise, and something you want to assess really carefully, especially with the open MCP dislocations. If you see one of those, it's really a high energy injury. and those are oftentimes really, really stretching the neurovascular bundles. You can have avulsions of arteries, you can have stretch injuries of nerves, and you want to make sure you assess that fully prior to going to the operating room, because at some point you may get in there and you might have to do a microsurgical reconstruction if you're not prepared. And then the precise location of pain, right? They might have a super swollen hand. You're not sure which joint it is or what the issue is. And you can really get a sense with the topographical anatomy of the hand where exactly they are tender. So if you can take a pencil tip or a pen tip and point to the area that hurts the most, then you'll have a good understanding where the injury is. And then my physical exam really starts with looking. You want to gain the trust of the child, and so look first and then touch last. So look for ecchymosis, edema, look for injuries to the skin, open wounds, bleeding, any deformity where you see either hyperextended posture or a sort of a dorsal dislocation. And then find out where the most tender. That gives you a good idea where the issue is. So, palpation over the point of maximal tenderness, if there's a physeal component to it versus just at the joint, and then range of motion. See if they have any range of motion. Is it weird? Most times the dislocation, they really have no motion at that joint, but they have motion at subsequent joints to make sure that they haven't had any tendon injuries. And then radiographs, right? You want to get a good view of the hand. So generally you want 3 views of the hand. For thumb dislocation, sometimes you want to get dedicated thumb views. But you want to look for subluxation, dislocation, or even widening of the MCP joint. And this one is fairly obvious. You can see that there's significant widening of the MCP joint of the index finger because of entrapped volar plate. We also look for overlap, right? If you see a proximal phalanx and a metacarpal overlapped on the PA view, then you know it's dislocated dorsally and shortened a bit. We also look for other injuries as well. You can see either, in this case, probably a sesamoid trapped kind of in the joint space. It's not an avulsion of the collateral ligaments, but that joint space is wide and overlapped, and you can kind of see on this view that there is a dislocation where it's about 100% displaced. And then if there's, most of the time, that's all you need for treatment for this. If there are large osteochondral fragments, sometimes we recommend a CT scan to see how big the piece is and whether it warrants fixing as well. Because oftentimes these are reducible, and then if they're reducible, if they're stable, you may not need to do surgery. So this is a clinical photo of a patient with an MCP dislocation. It's kind of subtle to see, but there's a fullness here in the volar aspect. And if you palpate, you actually palpate the defect dorsally. You'll see the proximal phalanx when it ends, and you'll feel a big hole where the metacarpal head should be, but it's actually volarly dislocated compared to the MCP joint. In this case, it's perpendicular to the metacarpal, which indicates likely that there's a complex dislocation. And we'll kind of show that schematically here. So when we classify MCP dislocations, we classify them either as simple or complex, right? So a simple, is generally dislocated dorsally. Oftentimes the collateral ligaments are still intact. The collateral ligaments, if you remember, are taut in flexion and looser in extension. And so if you hyperextend, those collateral ligaments lose some of their stress. The volar plate can be ruptured or torn, but it's not entrapped in the joint. And it's usually angulated or extended. So you see this angle between the proximal phalanx and the metacarpal. It can be 90 degrees, 70 degrees, something like that, but it's definitely not collinear. These are often amenable to closed reduction. And we'll go over the technique in a little bit. With complex dislocations, oftentimes there's something entrapped in the joint. Usually it's volar plate. I know the old textbooks used to talk about the lasso of the flexor tendons and the lumbrical on one side and the transverse metacarpal ligament proximally, and you kind of get this noose. I've not seen that in kids. Certainly it's possible, but generally you have an entrapped volar plate. And that can have a sesamoid attached to it, and the sesamoid can be inside the joint. The sesamoids don't ossify till about age 10, so that's not something you look for in the younger kids. But you'll see this collinearity, right? The metacarpal and the proximal phalanx are at the same plane because the trapped volar plate allows the joint to then hinge forward again. And it's, either, like this, where you can see the overlap on the AP view, or they can be, distracted because that volar plate is really taking up space. So these are typically irreducible via closed means and may need to go to the operating room. So the technique that we use, a digital block is usually sufficient, but you don't want to use longitudinal traction, right? If you do longitudinal traction and pull traction, what you're going to do is take that volar plate And with the vacuum effect in the joint, it's going to suck the volar plate into the joint and possibly cause a complex dislocation. So what you want to do is hyperextend the joint and then push it forward. And that pushes it over the metacarpal head and then slowly reduce it down. And usually once you get it back over into 50, 60 degrees of flexion, it sort of pops into place and then it's fairly stable. Make sure you take post-reduction radiographs because you want to make sure that even though the finger is now from a hyperextended position to a straight position, it's not dislocated dorsally and collinear and fooling you, because a lot of the swelling you'll see will be really complicated. And then you generally splint them for 7 to 10 days, usually in a little bit of flexion, because you want to make sure those ligaments are a little bit stretched, so that 1, stabilizes the joint, and 2, doesn't allow for contracture. You can get into intrinsic plus positions in the fingers, or intrinsic minus positions of the fingers if you don't do that. So here's a simple dislocation. You can see it's hyperextended. There's some widening of that parent joint space. That probably just from cartilaginous intrusion. And then with just a simple reduction maneuver, you can see that the joint space is now narrowed. I have noticed, if you look at radiographs, I'm not sure if I can point this out very well, but the metacarpal head oftentimes is very flat in patients. So, the MCP joint has the most variability, especially in the thumb, of mobility. And so in some patients like me, my MCP joint on my thumb moves about 35 degrees. And so the metacarpal head is very flat because it doesn't rotate all the way around. And those are the patients that get dislocations, right? The ones that have a rounded metacarpal head oftentimes have normal hyperextension MCP joint down to flexion. I've seen up to 180 degrees of motion in that joint. And so it's hard to dislocate a joint that has that much mobility because it just gets out of the way when it gets injured. So that's something you can see if you look for it in the metacarpal head. And then for complex dislocations that you either try to reduce close, they don't work, or you can tell right away that they're complex dislocations. I've been able to, in some cases, do a lidocaine flush. So once you've anesthetized the joint, you can actually stick the needle into the joint space and sort of rapidly push lidocaine into that and try and push the volar plate out. With a little bit of traction, you can kind of open up that space and try and push the volar plate out. Sometimes it's really, really entrapped and stuck and you can't do that, but sometimes it works. And so I've had some success doing that just to flush the volar plate out and get it going. If it's not, then I tend to do a dorsal approach. So go to the operating room with a hand table, and then you get away from the neurovascular bundles. If you have an open dislocation volarly, I'll often wash it out volarly, but then go dorsally to reduce the dislocation to make sure we're not damaging the neurovascular structures and the flexor tendons, which are in the way. If you have 2 tendons to a joint, so thumb, index, and small, which fortunately are the most common digits to have MCP dislocations, then you can split between the 2 tendons to the joint, get down and see really, really well into the joint, and then use a freer elevator or something to dislodge the volar plate and push it back around. You sometimes have to incise a little part of the volar plate or cut it longitudinally to split it open enough to get around, but that heals back together pretty well. And then you can reduce the joint inflection and hold it there. Trickily, you do have to keep it kind of in a flex position to allow it to heal, and then start mobility. So in this patient, you can see that there's sort of the complex MCP dislocation, widening of the joint space, had to have an open reduction, but then got reduced nicely and put into place. So for our aftercare, we generally, if you have to do an open approach, put some dissolvable stitches in, you can suture the capsule back together if you want to, and definitely suture between the tendons to suture that space back together. And then for the thumb, I generally cast them for about 4 weeks. We don't really worry so much about thumb MCP mobility and more about stability of the thumb for strength. So I like to cast them. Usually if I'm taking the operating room to fix it, it'll be a movable or a splint for about 7 to 10 days, allow the wounds to heal. And once the dissolvable stitches are pretty well healed, you can transition to a waterproof cast because we offer waterproof casts and patients like that. And then they can get a brace. For the finger MCP dislocations, generally flex them down in an intrinsic plus position for 7 to 10 days, and maybe a little bit longer depending on how complex or difficult what reduction was. And then you can start them some motion, maybe some occupational therapy if they want to get back to sports, but you want to avoid hyperextension of the joint until the volar plate heals, which is about 4 weeks or so. And then, my general return to sports talk is motion first, strength second, and then start returning to sports. So sport-specific activities third, and then get back to it. A lot of patients want to go to sports first, and then they'll get the motion strength later. I think that's unsafe, especially if you're not getting paid to do sports, which is 99.9% of my patients. So the other things you have to watch out for are associated fractures. So something like this, where the collateral ligament is avulsed as well. Oftentimes these heal, but if it's a large osteochondral fragment or if it's unstable, you may have to go after it and fix it. So if you have, for example, a thumb MCP joint, a skier's thumbs, or a collateral ligament avulsion fracture, this is typically off the base of the proximal phalanx. They can have a large osteochondral fragment attached, which may or may not have the whole ligament attached to it. So if it's really unstable to stress testing, or it's a large piece that's not going to articulate well, if it heals in that position, then you may have to go after those and fix those. And the osteochondral fractures that we sometimes see with MCP dislocation, especially if you have a more shearing injury, as the joint dislocates instead of hyperextending solely, it shears off a piece of bone with cartilage attached to it. These may block reduction as they're floating in the joint, and they may necessitate ORIF if they're unstable or don't have good mobility. So generally, if you're reducing something like this and you see that there's any crepitus or instability or bony block to motion, you have to go after it and fix it. CT scan might be helpful to see. So this is a patient with a representative large osteochondral fracture that had to be fixed. So we had to move it in the right spot, put a couple of headless compression screws in to put it together and get it to line up the joint surface better. It was displaced. So that's my little spiel about the thumb MCP joint, everyone's favorite dislocation, and feel free to ask any questions, and I appreciate the opportunity. Thanks again.
Thanks, Kevin. That was that's a great talk. Very, really illustrative. There's a couple of questions on the chat. What percentage of thumb MP dislocations, dorsal dislocations, do you think need reduction, open reduction? And do you think is there a difference between the thumb and the finger, the digital MP joints in terms of that?
Good question. I would say I think the thumb is usually a bit easier to reduce. In my experience, like 10 to 20% may need open reduction. It's honestly been like 5 or 6 years since I've done a thumb MCP open dislocation reduction, and we get them, a few times, definitely a few times a month in our ERs. I think the finger's a bit more tricky because there's more tissues around, and I think more likely to get the volar plate entrapped. So I've had to do more with fingers than thumbs, but still, I would say more often than not, it's reducible closed. So at least 50%, especially if you're teaching people the right techniques. I think it's, even with the lidocaine flush, you can certainly sort of augment closed reduction and get it successful. So I always have people try. It doesn't hurt to try. If it doesn't reduce, then you still have to go to the OR. So.
The other question relates to the osteochondral fracture or fragment. How often do you think you see that as a significant enough to warrant fixation?
That's pretty rare. I think more often than not, the joint just dislocates. Those have to be more high energy injuries, like when you're jamming your finger, like a goalie who hits the goalpost instead of the ball, like jams their finger at high speed. Those sorts of things. So it's pretty rare, I would say. We don't have. We see a lot
of those with so Australian football, for example, it's a pretty heavy projectile, and you see a lot of without the dorsal dislocation, you see a lot of Salter-Harris 3 fractures at the base of the proximal phalanges, and I think they're quite a hard fracture because they're sometimes just displaced enough to warrant doing something about them, but they're hard to get to, and the fragments are small.
Yeah.
For that sort of fracture, what do you do? Do you go? I go from the front, but is that your practice as well?
Yeah. So if I see a Salter-Harris 3 of the proximal phalanx, I will try and go from a dorsal, and I try to perk pin it. So what I'll do is, if it's in the fingers, I'll actually flex the MCP joint down and put a K-wire through the back of the hand. I don't know if you can see my hand here, but put the back of the hand down to the base of the proximal phalanx. and then I can joystick that piece and put it into place, and then drive it across. And so I drive it across, then pull it out the finger, and so the back end of the K-wire then goes into into that fragment, and so that allows for the reduction to happen from a dorsal type of approach. I have had to go volar a few times to get to those. It's just a lot of stuff in the way to get down there. And if you think of like the MCP joint, the MC flexion crease is this distal palmar crease, or proximal palmar crease in the index finger, and so that is that's pretty far down the hand, and so to get there's a lot of structures in the way. You get into the muscles, you get to the lumbricals and that sort of stuff. And dorsally, generally you can get to the whole joint. Like I showed with that finger MCP osteochondral fracture, if you split the tendons and flex the joint down, you can see the whole metacarpal head just sitting there nicely. And so even if it's a piece of bone that's pretty large, even towards the volar aspect, you can get to it from a dorsal approach. But those proximal phalanx ones are difficult. So
now Yajana from Finland has would like to say something. I think are you there? Why?
Ariana?
Yep, I would just like to comment on I'm good. Thanks for a great talk. Could I comment on making the diagnosis? I personally prefer not to touch the patient at all after seeing swelling, or if I kind of expect that there is a fracture or dislocation, I just take an X-ray, and if there is nothing, then I will check the range of motion and stability of the joint. I think it's basically a little bit unnecessary to touch the patient if there's a high risk that there is a fracture or a dislocation.
Yeah, I mean, that's the standard orthopedic physical exam, right? Take an X-ray and put it up on the board, and then you can diagnose most things. I think in our position as attendings, most often the X-ray's already been done for us, so we kind of know what's going on. So there are occasions we get the late presenter or something like that, and then you have to diagnose them and then clinically, and then get an X-ray because they don't come with one. But I agree, if you see a significant deformity, you may not want to touch them too much, but you can certainly palpate gently without hurting them to feel, especially that step off you feel from the proximal phalanx being over the metacarpal head. You can feel that divot. You don't have to press very hard. You don't have to hurt the patient to do that. So
there's one, just what you just mentioned then, there's a question about late cases. Do you see the neglected case, and if so, or the case that presents late, just a week or 2 weeks or 3 weeks, and if you do see that, does that change your approach?
Yeah, so I've not seen an MCP late presenting. I've seen a PIP, a month after reduction that never took post-op X-rays that was dislocated again. So if it's more than like a week to 10 days out, it's probably not going to reduce easily in clinic, and so you put them to sleep and try closed, and then if that doesn't work, then you have to do an open approach. So if it's been too much time since the since injury, it's probably not reducible because the callus is setting up in the joint and blocking reduction. So you have to really clean out the whole joint to get it back into place.
Just one, like there is the volar approach described, which you mentioned, and I guess the advantage of that is that you can repair the structure that is damaged, as in the volar plate, but you don't find that that's necessary. The volar plate scars up enough.
The volar plate scars up enough. So like one of the other questions in the chat was like how long to immobilize after open approach, right? If you can flex the finger down and prevent hyperextension, then the volar plate kind of heals on its own. It's the hyperextension of the joint which really starts to pull things apart and makes the joint lax. I
certainly see that with the thumb. You see kids who've got that, who've had maybe they've got a hypermobility, or they're presented with a painful MP joint that's hyperextended. It's been pushed back into place, and then it's an ongoing issue. They're back in your office every 5 minutes with hyperextended again. Do you think there's a place in that sort of recurrent instability for sort of volar capsulodesis?
There is. I think I try to be a bit more aggressive with the thumb, especially, we talked about you don't need the thumb joint mobility as much as stability at the MCP joint. And so I'll be more aggressive in casting those patients for 4 weeks after injury, even if it's, closed or open, it's like always casted. So that seems to limit that. My thumbs do that too, where I don't hyperextend, but I've dislocated. Like if I have a heavy object on it, my thumb will dislocate 90 degrees and then pop back into place. And that happened first in high school, and it keeps happening to me. So it's something that's a recurrent stability issue. Even when I put like a big clamp in the OR, sometimes I push the clamp and my thumb like pops out. It's really painful. But then it pops back in, so I just keep operating with like, the base of my thumb though, to hold it. So.
You haven't thought about an operation, Kevin?
No.
Not yet.
Not yet. If it becomes too symptomatic, maybe, but it's been like 3 or 4 years since I had one, so I've learned how to avoid it in most cases.
I think that sort of covers it. Zesco,